My name's David Armstrong. I'm the Director of the Health Workforce Technical Assistance Center. Today's meeting, as you can see by the slide in front of us, is on clinical faculty and educator development, a call for transformation. And we're joined by Garrett Chan, the President and CEO of HealthImpact, and Eddie Burns, or Eddie, or Edward. We were debating this to begin with, and so we're just, well, it says Eddie, so we're going to go with that. And he's the Director of Strategic Initiatives for HealthImpact. So welcome you both, and welcome you in the audience. And for the audience right now, just a quick question for you. If you could let us know in the chat what state you're from, I'd be interested. It's always kind of interesting to see where people are coming from. Well, if that's said, I'll go ahead and turn over to Garrett and Eddie.
Thanks so much, David, for the opportunity. Yeah, absolutely. It's exciting to be here with a lot of our friends and colleagues from across the country. Thank you so much for the invitation, David and Michael. So you've given our introductions, and so we're going to talk about where HealthImpact has been as it relates to clinical faculty and educator development. And I'll say that we've done an environmental scan of many different organizations across the United States. And I had the opportunity to be at the summit that the U.S. Department of Health and Human Services Region 3, of which I see Becky is part of. So shout out to Region 3 and all the great work that they're doing. How we're approaching, clinical faculty and educator development. So I think I'll just jump to the next slide, Eddie, and then have you do the next slide.
This one, Garrett. Oh, yeah, okay. So as Garrett mentioned, we are utilizing Dr. Patricia Benner's work in 2009 and 10. She worked with the Carnegie Foundation and looking at how we're training the professions, looking at medicine, law, I'm going to forget one, Garrett, medicine, law, nursing, clergy, engineering. Yes, I remembered all 5 of them this time. I'm proud of myself for that. And this study was really looking at how we're educating these professions, how we're coming into the professions, and looking at the 3 universal apprenticeships, the cognitive, the practice, and the ethical comportment and role formation, being universal across these 5 professions and how we're practicing. That was almost 14 years ago that we had this call for radical transformation from Dr. Patricia Benner and colleagues, and we're just not seeing it, that academic practice gap, that as these new nurses are coming out of practice and stepping into this real environment, that gap just seems to be getting wider and wider. And so we have taken quite a stance at HealthImpact and created the Benner Institute for Teaching and Learning. And we are excited to talk today kind of some of the things that we're doing in California. We wanted to start out first, if we could, Garrett and I just like to open things up and kind of just establish a little relationship with each other and just pose a question, and we can use the hand raising feature as we were saying. What does a caring educator look like in today's practice? Just to kind of have a little dialogue and start there. Jump in. I see Becky.
Yeah, finally, right? Someone says something, right? I think Karen, as an educator, is recognizing and respecting your students and listening to them and hearing their experiences and trying to integrate that in with it instead of just a one size fits all. It's understanding where people are coming from.
I love that one size does not fit all, right? It's great. What else comes to mind when you think of what that caring educator looks like in practice? Patience and understanding, I see from Michelle. Yeah. can move on. Thanks for those that did share. That's great. I think it's always important to, kind of think about why we're here, why we are passionate about the work we do as nurses. And so it's great to always think of some of those positive things about our roles and what we do. And it's hard right now in today's, current practice environment and what we've all gone through in the last 2 to 3 years here. Being caring is sometimes difficult. So I think it's important that we have that conversation. So I really appreciate that.
Eddie, I'm just going to call out what Tiffany
Jump
said before we move on. Tiffany said taking a student where they are and moving them to where they can be and not expecting them to be just like you. So that's beautifully said. Thanks, Tiffany. And actually, we're going to circle back to the last comment that you made about them not expecting them to be just like you in kind of a couple slides from here. On the next slide, I'm sorry, Eddie, go ahead.
No, that was great. Thank you. I missed that.
No worries. So one of the things that we have really focused on, and we've been working closely with Patricia in the development of our courses, and we just actually saw her last weekend to do more refinement of the work that we're doing, is that sometimes, maybe not all the time, but more often than not, I would say, that people in clinical education, whether they're clinical educators on the agency side, whether they're clinical faculty on the academic side, or even preceptors, are not quite sure what the North Star is of clinical education. Unfortunately, oftentimes we are really focused on the logistics and the operational. Can I find enough, preceptors? Do I have enough clinical sites? I mean, this is a big issue across the country. And so as we start talking about, well, what is the goal of clinical education? We looked back at some of Patricia's past work and really found this important quote from Expertise in Nursing Practice, which, for those of you who know, is the second book after From Novice to Expert. So Expertise in Nursing Practice is really intended to be a further explication of Novice to Expert. And what Chris Tanner from Oregon Health Sciences University and Kit Cheslaw from UCS, the University of California, San Francisco, wrote back in 1996, and then with the second edition reinforced this concept that an important goal of clinical education is to move learners from seeing the clinical world as being elemental, partial, and dominated by tasks and procedures, to engaging with the clinical world as a nurse, to see meaningful clinical patterns and an increased understanding of the whole patient or family or community situation. So this is how Eddie and I have constructed all of our courses, which is really to help them move from this elemental, partial, and task-based world into engaging with the clinical world to see meaningful clinical patterns and an increased understanding of the whole patient, family, or community situation. And again, we've done a environmental scan of many programs out there, and they're all very good. I don't want to minimize that at all. And one of the things that we found that is different from our perspective than others is we are focusing really on the engagement with the clinical world and kind of moving beyond the elemental, partial, and domination of task and procedures. Unfortunately, from the acute care side, there's a lot of focus on tasks and procedures. We really, and we'll talk about this kind of as we continue on, but there's a lot, when we do competency checklists, what do? We check off your IV insertion skills, and we check off chest tube management, and pain management, which are all important, but they're really not the work role, clinical competencies that Patricia and her colleagues have talked about. So as we're moving from the goal, I want to talk then to the next slide about the purpose. So again, gathering a lot of data from what Patricia's work is really trying to articulate, well, what is the purpose? So we have the goal, right, to have them get immersed in the clinical environment, seeing patterns, developing clinical imagination. But what is the purpose of clinical education? Why do we do it? And so we have come up with 5 different purposes for clinical education from our perspective. They are first to develop, or one is to develop and describe a perceptual grasp. So how do they see and how do they notice what's going on? Developing a sense of salience. We'll talk a little bit more about sense of salience. But sense of salience is determining what is important in this situation for this particular patient. Developing clinical reasoning and judgment, and clinical imagination in particular clinical situations. The second purpose of clinical education is to help the preceptees, whether they're nursing students or new grads or even nurses beyond, to understand the notions of the good that's internal to the practice of nursing, to develop advocacies for individuals, families, communities, and or the social good, like equity. So how do we help our students understand what are the goods of the profession, and how do we carry those notions of the good forward and in their formation in becoming a nurse? On the next slide, the third is to have the preceptee respect humanity and give social space to develop skills of involvement and relationship building. And this is really focusing on, in our current language, again, some of these writings are some years old, of diversity, inclusion, and belonging. How do we help our preceptees, again, nursing students or new grads or whoever we're teaching, to open up social space to develop a relationship and get involved in the life world of their particular patient so that they can understand the issues that they're experiencing in their illness trajectory? The fourth is to develop a reflective, self-improving practice. How do they learn from the situation? How do they learn from other professionals and from mistakes or failures? And how do they guard against bias? So it's through experts like clinical faculty, clinical educators, and preceptors are nursing students and new grads able to understand the reflections and how do they self-improve their practice so that they can go along the trajectory of skill acquisition from novice to advanced beginner to competent to proficient to expert. And then the fifth purpose of clinical education is to develop competence in the 9 work role competencies. And hold on, because there's a graphic kind of next. So when we created our particular program, we talked a lot with people in practice to kind of gut check, if you will, these particular purposes of clinical education. Because at the end of the day, we're hoping that they graduate, they pass the NCLEX, and they enter into the workforce. And so practice is saying, yes, they don't use these words necessarily, but as we talk with them, they were alluding to these 5 purposes of clinical education. And the outcome is really having these new grads feel comfortable in the practice of nursing. So on the next slide, what we've, I will talk about this slide and then I'll show a graphic on the following slide. So this slide is, what is experiential learning? Now, Patricia talks a lot about learning from experience, or experiential learning is essential. And there's nothing better than the clinical world to actually learn through experience. Now, when she talks about the clinical world, it's not just direct patient care. It's also in simulation. It's also understanding the world through narratives or unfolding case studies. So when we talk about experiential learning and experience, it's not necessarily always direct care. It's high quality educational pedagogy. And experiential learning. So if we think about, we say the word, but what does that actually mean? Well, what it means is that there's a nursing student, for example, turns around preconceived notions or perceptions of the situation. I learned this in class about heart failure, and but my textbook never taught me about what happens with a patient with heart failure and liver failure with ascites and its third spacing. So while they come in with some information about heart failure in one class and then perhaps liver failure and ascites in another class, putting the two together is not necessarily in any textbook, right? So what they do is they enter into the situation, and it's through expert preceptor and clinical faculty or clinical educator guidance are they able to turn around what they previously understood about heart failure and perceive the situation in a different way. Experiential learning is also adding of nuance to preconceived notions or perceptions of the situation. So what is more nuanced? What are you seeing that is beyond the textbook? Sorry, can you go back one, Eddie? And then experiential learning is also amending or changing preconceived notions. So it's turning around, adding of nuance, or amending or changing preconceived notions or perceptions of the situation. So so commonly we hear, well, how do you do that, right? And what you had said earlier, Tiffany, about not expecting them to be just like you, is that, you know, oftentimes what we have seen in the history of clinical education is the adage, see one, do one, teach one, right? So see one means I'm supposed to watch you so I can do one, which is to do it like yourself, do it like the preceptor or the clinical faculty, and then teach one. So what it does is that actually we know practice is more nuanced than that. It's not just cookie cutter. We're trying to stamp out everything that we know onto you, and that you are just having this received view of, oh, I'm going to be now imprinted with this. But really, it's about developing clinical understanding and judgment, clinical reasoning and judgment, to, you know, maneuver through these clinical situations. And we see that, and you all are expert nurses, right? And so you know that your practice now is different than when you first started. And that's our job, is trying to help our learners teach their nursing students or new grads how to learn from experience and the goals that I mentioned, goals and the purposes of clinical education that I just mentioned. So on the next slide, we also know, again, that one size fits none, or that there are different levels of learners, and there's nuanced clinical education. So we talked about the goal of clinical education, and the goal should always also be tailored to the individual preceptee's particular learning needs. We'll talk about the interventions. They may be the same, but the depth and the complexity of the interventions and preceptee expectations are different. So we also know that competent level preceptees can be coached to notice how more attuned their sense of concern or anxiety about patient's clinical condition has changed with experience in similar and contrasting patients. So one of the things that we know through research is that as somebody goes from novice to advanced beginner to competent to proficient to expert, is that the things that the novice is concerned about is not what the competent nurse is concerned about, which is not necessarily what the expert nurse is concerned about. That we change over time, and we change if we engage with our practice where we're reflective, and we can see subtle nuances, and we're concerned about different things as we progress. So on the next slide, we think about, when we are talking to our clinical faculty and educators and preceptors in our educational programs, Eddie and I talk about, well, what happens? What does it look like if you're going to be with a first semester nursing student? What kind of structure do you have to put into place? How much detail do you have to give? How much pointing out do you have to do with these novices versus advanced beginners versus hopefully late advanced beginner or early competent new grads? Again, the interventions that I'll mention in a bit are the same. It's just how much structure, how much coaching do you have to do depends on where they are in their educational program. So on the next slide, we also talk about, people use the word competencies kind of generically, but the literature actually is helpful, especially in the education literature. It's very helpful for us to understand different types of competencies. And so the framework that we rely on, or that we ascribe to, is that there are what we call enabling competencies, and there are work role clinical competencies. Okay, so for example, an enabling competency is a technical competency that's required for the role competency. So inserting an IV, learning ACLS, BLS, PALS, or neonatal resuscitation program, or de-escalation techniques for patients with a psychiatric mental health condition, right? Those are very important. We would never say that the enabling competencies are not important, because they absolutely are. And yet, when we think about the practice of nursing, there are these what we call work role competencies, which are high-level, complex competencies for the practice of nursing. And so on the next slide, what we've done is we've created a graphic, and I'm sorry, it's kind of hard to see. Hopefully you can see it bigger on your screen. Is that we have created this clover leaf where we show how there's this interaction, if you will, between various things that Eddie was talking about and the things that I've been talking about today. And so I'll start from the top left, kind of at the 11 o'clock position. So Eddie mentioned in the introduction that we've taken a lot of our work from Patricia and colleagues' book, Educating Nurses, A Call for Radical Transformation. And Eddie mentioned the 3 high-end professional apprenticeships. Again, across these, I'm just reiterating what Eddie said, was across the 5 professions that he mentioned, that they found that there are these 3 professional apprenticeships: the cognitive apprenticeship, the practice apprenticeship, and the ethical formation and compartment apprenticeship. And really what this does is it helps us understand how do we form, if you will, somebody in the professions. Cognitive apprenticeship, just very briefly, is what are the scientific principles that we need to know, pathophysiology, pharmacology, therapeutic communication, et cetera. We need those foundational components in order for us to be able to engage in the practice of nursing. The practice apprenticeship is how do we use that foundational knowledge in the interactions with our end populations, be them individual patients or families or communities, and how do you integrate that? So this is where, again, clinical faculty, preceptors, and clinical educators play an incredibly important role. And then ethical comportment, or how do we hold ourselves out in the world, and formation, how do we form our ethical understanding of the situation, also comes strongly through clinical education. So those are the 3 apprenticeships. She mentions in the book 4 paradigm shifts. The 4 paradigm shifts are from, the first is from critical thinking to clinical reasoning. There's a very distinct philosophical, theoretical, and operational distinction between critical thinking and clinical reasoning. Critical thinking is use of scientific reasoning, and it's a very cognitive process. We use it in times of breakdown. We use it as new nurses who are starting to learn the nursing process. It's incredibly important. And yet, if you think about your practice now as expert nurses, you don't really think about things cognitively. You don't look at them by concepts. Nothing is necessarily, or very few times are things in a situation of breakdown. But clinical reasoning is, how are you perceiving the situation and how are you expertly responding to the needs of the situation? The second paradigm shift is from socialization and role-taking to formation, a dance of self-understanding, relationship, and commitment. So we talk a lot about in nursing historically about the concept of socialization. I'm going to socialize you to be like me. You are going to take the role that I have taken. And what this does is it unfortunately, linguistically as well as theoretically, it doesn't really recognize that each individual person is going to approach a situation in a different way, even as expert nurses. Right? There will be some similarities, of course, but there are also different ways to reach the same endpoint, which is the concept of equifinality. And so, really, from just again the concept of stamping somebody, to be like us, is socialization and role taking, versus formation, which is an intrinsic way of approaching and developing one's own clinical nursing practice. The third is from abstract, isolated didactic content to a cohesive clinical application for a sense of salience and situated knowledge. So sense of salience, as I mentioned, was noticing what was important, what stands in the foreground is important, and what can recede in the background, which is perhaps less important. That's what expert nurses do at a drop of a hat. Novices really struggle to try to figure out what's important in the situation. But we as clinical faculty and educators can really help develop that sense of salience and perceptual grasp. And then the fourth paradigm shift is from curricular competencies to integration of the 3 high-end professional apprenticeships. So again, what do we have to have? We all have to have them in our educational programs. What are the curricular competencies, right? If you're an accredited program, ASIN, CCNA, the NLN Accreditation Corporation, you will have to have those. For your state boards of nursing, you'll have to have those. But those are important, again, no doubt. And they're not sufficient in the development and formation of a nurse. The area kind of where it says 5 Eiler aspects, we use learning and neuroscience to guide our teaching in our programs through the Benner Institute, based off of Dr. Josh Eiler's 5 aspects of effective college teaching. And Josh is not a nurse. He is a PhD in education. He's at Ole Miss now, and he wrote a book, and he articulates these 5 aspects. And using these 5 aspects helps increase the learning of students. And so the 5 aspects are curiosity, sociality. So how do we create a social environment to encourage learning? How do we use emotion to get students engaged? Authenticity, so the more authentic we are as people, as educators, the more authentic the cases that we can present are, the more that they can actually learn and use that learning in future practice. And then failure, learning from failure, right? Pretty easy. So we incorporate Eiler's 5 aspects in our teaching, and we teach our faculty and clinical educators and preceptors about the 5 aspects. And then this kind of goes back to the 9 competencies. I mentioned the purposes of clinical education and for the health impact, from the health impact perspective, are these 9 work role competencies. And again, different than enabling competencies, I think these competencies may resonate with you. So for example, one work role competency is diagnosing and managing clinical conditions. Okay. Whatever that clinical condition is for whatever specialty you're in, that's a work role competency. Second is the skilled know-how of managing a crisis. Things go sideways all the time. How do you manage through that crisis? And how do you have that skilled know-how of doing so? The third is providing comfort measures for patients, families, and communities. The fourth is caring for, oops, that's a mistake, sorry, it should be caring about patients, families, communities, and self. So caring about as opposed to caring for. The fifth is preventing hazards in a technological environment. The sixth is decision-making and caring in advanced illness, loss, and end of life. That is specifically called out as opposed to the caring work role competency because we know that nursing students and new grads really struggle with end of life care. And so that is separate for a particular reason. The seventh is making a case, communicating assessments and improving teamwork. The eighth is patient safety, monitoring quality, preventing and managing breakdown. And the ninth is the skilled know-how of clinical and moral leadership and the coaching and mentoring of others. One of the examples that we teach our clinical faculty about in our programs is how do you help nursing students or new grads when they see that substandard care is being delivered? That's a moral issue that needs to be addressed. And so how do we help mentor those newer nurses, or sometimes even more experienced nurses, in maneuvering through that particular type of situation? So, I just share this because it really serves as a graphic for our learners to remind them that this is what we're trying to do. This is what we're trying to educate them for, is to address the 3 apprenticeships, the 4 paradigm shifts, the 5 Eiler aspects, and the 9 competencies. So on the next slide, we have this is where Eddie has really done a great job in ensuring that our faculty think about pedagogies of care and empathy. So Eddie, I'm wondering if you would go over the slide.
Sure. So these are lots of hot buzz topics that we're all very familiar with right now in the current practice environment. And Garrett and I really take a lot of time in the virtual environment to establish psychological safety, utilizing principles of trauma-informed care. And one of the big distinctions also that we're trying to make, coming around here at 4 o'clock, and Garrett kind of said this in the competencies, is that there's a big distinction for caring for someone and caring about someone. And so this is a part of the work that we're ensuring we're bringing forward with not only the faculty, but also with the students. And this is where caring for yourself and self-care kind of lives in here too, and about how we care for ourselves and about ourselves. And so we're really taking some time to differentiate that and equip faculty with tools to be successful to establish psychological safety, different icebreakers, different ways that they're able to make sure that therapeutic relationship is constantly being nurtured. We also obviously know that healthy work environments and kind of that everything around workplace violence right now is something that we're also ensuring we're focusing on, looking at different strategies. As Garrett mentioned, there's different tools that we're utilizing in our programs, looking at the concerned, uncomfortable safety, the cuss words. We're also looking at a few other models, our ARC model, as well as a few other, the other one is Garrett that we're using, ARC, cuss, Oh, the nurse mnemonic. We're also using the nurse mnemonic to help with some challenging and difficult communications and crucial conversations. So we're giving them a lot of that cognitive component of how do I use and what can I use in my practice. But as Garrett has been saying throughout, we're really emphasizing the how, the practice component. What can they take back to their students, to their practice settings to help support the pedagogies of care and empathy. So those are just a few examples of some of the things that we're doing to ensure we're infusing care into everything that we're doing in this program. I can talk about this one too, Garrett. This is the definition of caring that we are utilizing within our programs. We define care as the alleviation of vulnerability, the promotion of growth and health, the facilitation of comfort, dignity, or a good and peaceful death, mutual realization, and the preservation and extension of human possibilities in a person, a community, a family, and a tradition. Really helping guide the way that we see care and how we offer that as a discipline, as a practice, as a nursing profession. And it's really important that we have these explicit conversations, especially as we're coming out of COVID and what that looks like. And so we're really taking a lot of time utilizing that pedagogical care model, as well as our definition of caring, to ensure that we are supporting and cultivating caring practices in all of our programs. This is just a little assessment that we do. It's called the Honey Mumford, and it's expanding upon our learning styles of the traditional, visual, auditory, reading, oral, kinesthetic, the VARPs. We're really diving into how we interact with the world. We all need to utilize those visual, auditory learning styles all the time in our nursing practice. I always laugh when new grads say, "Oh, I'm a visual learner," and I'm like, "Well, you better learn how to be kinesthetic, because you do that a lot in nursing." And so we are expanding on that. We're taking it to the next level. Honey and Mumford, I think you have it in here, Garrett, right? This breaks you down into 4 different ways that we interact with the world. I'll start up here with the activists, reflectors, theorists, and pragmatists. And this is really helpful for faculty because it lets you know kind of where a student may be sitting, or maybe some of the patterns that you're seeing. If you have one of those students that maybe is a little bit more on the quiet side, or a little bit apprehensive, and you can see kind of some of that anxiety that they're experiencing, take a moment and step back. Maybe this individual is a reflector. They need to collect a lot of things. They need to take in a lot of information and kind of be that wallflower sometimes to know where and how they fit in specifically with that interaction in that practice setting. So if you are someone who's very much an activist as a faculty, as a preceptor, as an educator, you're ready to go. You want to hit the ground running and just, let's do this. Let's get hands-on and get in there. That's going to be difficult for one of your students that's a reflector. And so Garrett had mentioned, and I think it was, I forget who it was, maybe Tammy at the beginning, was saying that one size doesn't fit all, and we can't do it specifically. Maybe the way that fits for us may not work for one of our learners. And so we're expanding on this with our faculty and our educators, and having them take a deeper look at the way that they interact with the world, the way their students are interacting with the world. Because when they have a better understanding of that relationship, it opens up so many possibilities for the learning experience. A few of the other ones, I know I'm just being mindful of time too. I kind of talked about this. Why is that important to understand? These are a few of the other ones that we're utilizing as well at HealthImpact. Standout is one that was created through Gallup and Marcus Buckingham over the last decade. It's being utilized in many academic medical centers. You can do it for free. They do offer a free one. It looks at 9 different kind of personality types in the way that we interact with the world. They provide 2 dominant personality types, and then you will get kind of like a printout of about a 10-page report looking at those. And then you have the opportunity, if you wanted to purchase the additional reports and kind of interactive components that come with that in the dashboards. One of the other ones that we've been utilizing, kind of is off here, Strength Finders 2.0 is positive psychologist, Dr. Clifton. This one is a great one to do with teams. You can kind of use it for the whole group. It does cost $20, but it provides, I think, 34 different characteristic traits that they kind of rank for you, and it gives you a better understanding of how you're interacting with the world as well. Just some resources that are great and free, obviously, the Honey Mumford and Standout to use as faculty. We're all about free in nursing, bracing and extending free. We love that. And then I'm going to turn it back over to Garrett, and we're going to jump back into kind of sense of salience. And we touched on this a little bit at the beginning when you were talking about our 5 purposes.
Great, thanks, Eddie. So the sense of salience. So we've talked about, that it's important. And if you, again, reflect on your own nursing practice as experts, when you walk into a room, let's say as a patient, and you can immediately figure out what the issue is, that is sense of salience. The thing that stands out in front of you and other things fall in the background is that sense of salience. And so how do we help our nursing students and new grads develop a sense of salience? And so that's kind of the age-old question, right? On the next slide, we talk about perceptual graphs. So perceptual graphs is more encompassing. Sense of salience is a part of perceptual graphs. So perceptual graphs is with familiar clinical situations, preceptees are likely to have a good perceptual grasp of the nature and the meanings of clinical situations that they encounter. They have a sense of what's going on. Then the sense of salience is like, this is the important thing that you need to pay attention to, right? So perceptual grasp is experientially learned. And that's what, going back to experiential learning is so important, is that you can only develop perceptual grasp based on prior experiences. And it's most astute and attuned when the clinician has deep background experience with similar and distinct clinical situations. Perceptual grasp is a recognition of the particulars of the situation, and again, repeated exposures to similar experiences allow for the recognition of resemblances. So how is it similar? And the qualitative distinctions, nuanced differences, peculiarities, and patterns to show up for the practitioner. So saying it in a different way, the nurse's maximum grip of the situation is to have a sense of optimal gestalt. So again, expert nurses, proficient nurses definitely have it. And it's how are we as clinical faculty and educators helping our preceptees develop along that same trajectory in a structured way. On the next slide, I talk about how it shows up, and I think I'm going to skip this for the sake of time, but I think you understand the concept. Again, as expert nurses, I mean, there have been times when I've, as an expert nurse, have seen as an emergency nurse, seen plenty of patients with neurologic deficits, stroke, Bell's palsy, migraine perhaps. But I've never seen, prior to my arrival to Stanford, I had never seen a disease called moya moya, which apparently only about 3,000 people in the world have, and Stanford apparently is a center for excellence for this. And it's a neurologic, neurovascular, also soft tissue disease. And so a patient came in with some neurologic deficit, and they said, oh, well, I have moya moya. And I'm like, I have no idea what that is. But I have seen neurologic deficit before, and I know how to approach neurologic deficit as a nurse. So even though it's a pathology that I had no awareness of, I was able to fall back on some of my past experiences of dealing with patients with neurologic deficit to try to figure out how to navigate through the situation. So that's why development of a sense of salience and perceptual grasp is important to foster. On the next slide is the answer to the question, like how do we develop perceptual grasp and a sense of salience? And we do it through situated coaching. So situated coaching is on the next slide, Eddie, is coaching the preceptee for situational awareness, noticing and responding to the most salient clinical issues in the situation. So, for example, as I mentioned before, we may enter into a room. The patient, I'm going to use your example, Eddie, because it's a good one. The patient is cyanotic, tripoding using accessory muscles, right? So an expert nurse walks in the room and they're like, oh, impending respiratory, failure, right? Or at least extreme respiratory distress. Goes immediately for the oxygen, may call a code or an RRT, and they're already engaged in the situation because they are experienced and they've seen this before, right? The new nurse or the nursing student's like, what is going on? This is happening so fast. I have a checklist. What's the vital signs? What's the O2 sat? And so as if the preceptor or the clinical faculty is narrating, oh, I'm noticing the cyanosis, and I'm noticing the first semester student notices that something is wrong. That's great, but they don't know what is wrong. So if we can narrate, what's going on, then it helps develop their situational awareness and what are they supposed to notice. I'm noticing the perioral cyanosis, right? I'm noticing the tripod and the extreme, use of accessory muscles. It helps them make that connection. And then clinical reasoning, it requires knowing how and when. So Eddie said earlier, oftentimes we have focused a lot of our education on knowing about something, knowing why something happens. Again, incredibly important. We haven't always, and the research shows that they don't always know how and when to use the knowledge that they have. So this is what clinical reasoning is about, is knowing how and when. On the next slide, so I use the word situated coaching, right? Well, so, we think about coaching as coaching like in sports, right? Or maybe even life coaching. But what is kind of the game, if you will? If you think about a basketball coach, the basketball coach is coaching the game of basketball. Well, what is the game that we're coaching here, if you will, in nursing? And so the game, if you will, is the purpose of clinical education, which is developing, and this is a repeat of what you've seen before, which is developing and describing perceptual grasp, a sense of salience, clinical reasoning and judgment, and clinical imagination in particular clinical situations, understanding the notions of the good in terms of the practice of nursing to develop advocacy skills, to respect humanity and give social spaces, to develop skills of involvement and relationship building, develop a reflective self-improving practice, learning from the situation, and developing competence in the 9 work role competencies. So, sometimes I hear that, and I've seen, honestly, that nursing students are sitting at the nursing station and they're kind of bored, right? And it's like, well, there's so many things that you can be doing, right? Let's work on, humanity. I mean, I would not use these words with them, but you could say, let's, from an educator perspective, let's figure out how the nursing student can develop create a social space to develop skills of involvement and relationship building, right, with their patient. The tasks are done, therefore they feel like they're done. But that's not the whole of nursing. So again, this kind of ends our presentation, which is, that's kind of where we're trying to get our educators and faculty and preceptors to go, is that particular game, which is the purpose of clinical education. So I'm going to stop here and leave 10 minutes for questions and answers and reactions. And feel free to push back, say, oh, I don't agree, Garrett and Eddie. And we'd love to hear that because it will only make our program stronger. So thank you again.
Well, we're a small group here, so don't be shy. Please feel free to speak up. I will say I found this very interesting. I always, being from a non-clinical background, I always find it fascinating when I hear aspects of the clinical work, which I kind of study from afar, being more into the workforce itself. So it's always very interesting from my perspective.
I want to thank you, Garrett and Eddie, because I'm working on a project here in the Maryland about how to improve our relationships with our clinical partners as schools of nursing. And we're trying to figure out a way to have a standardized method of sharing that information so that we're all on the same page. And what I'm working on, and this is so relevant, is what do we expect of our clinical instructors? You know, like when a clinical instructor is on a unit, people have these sets of expectations that the clinical faculty is going to do certain things. And when they don't measure up, then it's like, well, that's not a good instructor, or that's not a good experience. And I think these understandings of what the role is, what this clinical instructor is trying to accomplish, is extremely important, and that it isn't just about the task. It's about the thinking like a nurse thing that we really are trying to get at. And so this is so wonderful. I want your slides because I want to be able to take it to my committee and say, this is what it's all about. This is what we're really trying to do here. So perfect. Thank you so much.
Yeah, so we can definitely
Thank you, Becky.
definitely send us the slides. We'll share on our website, make sure everyone gets a hold of them.
Yeah.
You bring up such a
good luck.
Yeah, I would say you bring up such a good
Good
point,
luck.
Becky. So good luck.
Well, it's interesting because, well, as you know, there are different expectations from different groups. You know, the clinical instructor, the School of Nursing is trying to get at those thinking things, and people are looking at you're not doing things, you know, and how to bridge that gap between, yes, there are things we do, but what's going on between the two ears while you're doing those things is really that, you know, and that's why I don't like those time motion studies, because it does not get at all at what's going on in your head. So yeah, this is perfect. And I'm a bitter fan, so that's really perfect. So thank you.
Yeah, Becky, I think, oh, I'm sorry, go ahead, Selma.
I'm sorry, will you be sending a recording?
Yes, actually, if you register for this, you will get like a email when the video is ready. It will also just be on our website too. So if you by chance missed the email, check back here in a couple weeks.
Okay, that's wonderful. We'll send it on to the rest of the clinical faculty. This was really excellent. I think it's important to role model caring, and for clinical instructors to really know that that's what they need to do, because the students are like parents. You know, they see you be kind and extend, a loving hand, then they'll do that as well, right? But if you're abrupt and in a rush and, just trying to get the task done, then that's what they're gonna learn as well. So thank you for reiterating.
Thanks, Leva. And Eddie and I both our majority of our background comes from the practice side. And one of the things that we even struggle on the practice side is having like nurse managers and assistant managers, they'll say, oh, they didn't pass their meds by 9 o'clock. I'm like, okay, but did they take care of the patient? Did they take care of that patient among all the other patients that they had to take care of? And it's just really interesting. That's why we really called out the difference between an enabling competency. Again, we're not minimizing enabling competencies, but that's not the whole story, right? The whole story is both the enabling competencies as well as the work role competencies, which is, well, they were actually responding to a crisis in the next room over. And that's why they didn't get to their medications by 9 o'clock. So they were actually focused on the right thing. And yes, patients should get their medications on time. And yet they were doing the right nursing thing, which was responding to a crisis that some other patient had. So Yeah, there's other things that Eddie brings in. He does an expert job in talking about the clinical reasoning cycle. We use two models. We use the Tanner model from 2006, and we can put those. What we can do, David, before we send this off is maybe, Eddie, we should put our references. I realize now I didn't put a reference slide in, so I'll put the references in, and maybe we can also add the clinical reasoning cycle slides that you have for Chris Tanner and for the Newcastle model, because that's also very helpful and really beyond the scope here today. Yeah, Becky.
I know, I don't mean to be saying so much, but I'm really interested in some logistics. For how many people have you worked with? How do they come to you? Some of those kinds of logistics of how you're getting it out, and so how people are participating. I'd like to hear a little more.
Yeah, Eddie, can you go over that?
Do you hear me? I'm frozen.
Yes, we can hear you. Yes, we can hear you.
How about now? Okay, there we go. So you're saying, Becky, like from a logistics of how we're offering the programs right now?
Yes.
Yeah, sure.
Yeah.
That's sure. We're in a huge grant, a 4-year grant that we're doing with HRSA, Region 9. So California, Nevada, Arizona, Hawaii, all the Pacific Islands and territories as well. 208 schools of nursing. So they're being invited to send 2 individuals plus 2 clinical partners. So using a quad, they'll be invited to attend the clinical faculty educator certificate program. That we've done a total of 6 cohorts to completion. We did a pilot regional joint venture in the Bay Area in California, and that was kind of where we got the data so that we could apply for the HRSA grant. So then by doing that, we partnered with Western University, which is a private university in Southern California, nursing school, and they're very versed in HRSA grants. And so we partnered with them to get our first HRSA grant at HealthImpact, which was really, really awesome. So we received that last fall of 22. That'll go through the end of 26, right? Yeah, end of 26, essentially. So that's kind of how we're getting the whole recruitment piece, Becky, and starting with all of that. We are getting ready to launch the second part of our programming, which is the Nurse Preceptor Certificate Program. So that'll be the second program that we're offering. That actually is launching next Monday. So that'll be virtual as well. Modules that are completed virtually, and then there's an asynchronous Canvas component with that course. So quite a bit of movement as we're launching everything here in this first year, but we are ramping up quite nicely for the second year. So we'll be ready to enroll more individuals. And then to expand on that, we're also in a place now where we can offer it outside, you know what I mean? Both courses can be offered externally for anybody who's interested to be a part of the cohorts as well.
Have you thought about a trade and trainer kind of situation?
Yeah, we will
you
be
got
doing
a lot
that
of
eventually.
schools here. You got 200
Yeah.
some schools. So have you thought of? I've used that model, and it really seems to work. And you're covering a lot of territory, so.
We're hoping next year to start to dive into that. There is some plans to do some of the train the trainer. And so we're thinking year 2 will kind of be we'll have enough data and have done a few cohorts with the HRSA side of faculty and preceptors. And then we'll start to look at that data and how we can inform train the trainer, because we will create those models for both programs so that we'll have that in place post the HRSA grant, because we're only in Region 9. So we hope to be able to get to the other, basically 3.2 million nurses outside of Region 9. So we're hoping we'll have enough of a structure in place that we can then offer this to schools of nursing too, and be in a place exactly what you're saying, Becky, where we could have a train the trainer model and actually sustain that. So lots to come. It's exciting.
Yep. We do it online. There's 6 4-hour sessions. We've done, I think, 60 people so far with that model. And then we did a pilot 3-day intensive, in-person intensive, and we had 30 people in that. So probably close to 90. So yeah, just keep on going. And we're looking at the train the trainer model. So
yeah,
thank you.
I got another question. I'm so sorry. You can tell I'm really excited about this and engaged in it. How are you evaluating the outcomes? Is it making a difference when these people go out and utilize what they've learned? How are you getting at that? Or have you developed instruments, or are you using any, valid, reliable instruments, that sort of thing? And maybe you can just email me, because I don't want to bore people, but it just seems interesting to me. I'd like to say it's making a huge difference because I believe in it,
Yeah, we do have instruments. We can email them offline. We're looking at confidence and knowledge acquisition. So we're using the Kirkpatrick and Kirkpatrick model of evaluation of training and education. And so we're doing that, and then we're intending to do some follow-up too. Stephen Wilbur is from HRSA on this call, and so we have a whole plan, and we are happy to share that with you, Becky. And we're supposed to be also meeting with HRSA Region 3, I think in August, with the Pennsylvania Action Coalition, and so we'll be happy to share with them too. So you may hear something because you're on their expert panel as well. So it'll be great to have some more perhaps collaboration.
Thank you so much.
Sure. Michelle.
So thank you for this presentation. I'm glad that you're going to have a recording because, like I had said in the beginning, I had a competing thing that I was attending to at the same time. I'm here because I am in charge right now of a statewide nurse educator residency program that is funded by the New Jersey Department of Labor. And we were able to work to make the competencies of the nurse educator competencies an extension of the approved apprenticeship model of registered nurses. So I think that in some ways, a lot of our work mirrors each other in terms of what we're trying to achieve. I know that you're a little bit more focused on clinical education. What I wanted to say and share with you that I took from most of this presentation was that a lot of some of the conundrum, I guess, of clinical education in nursing is complicated with the different agencies where we have clinical partnerships and what have you. And I think a lot of what you're talking about is wholly applicable to simulation, which is the other life that I live in. And I think that I was really taking from this that we're trying to, in New Jersey, through Rutgers University, add simulation as a part of educator training, because many schools, recognizing some of the challenges with clinical education, are expanding simulation program without really thinking about how they're preparing simulation educators. And I think that there's opportunity, and I'd love to talk to you all about this, to create almost like applying these to the simulation environment kind of concepts. That is probably something in the future. I know that my school is definitely moving to an increased use of on-site clinical education, not all of it being high fidelity simulation, but clinical learning that's occurring on site that is counting for clinical education requirements by boards of nursing. And I think that, and I know that other states and schools are looking at expanding the concept of on-site clinical learning as a way to meet some of the challenges with actual clinical learning environments. And then you have the whole community-based context too, because I think that when we're preparing clinical educators, one of the hardships is oftentimes these clinical educators are coming from acute care environments where there were bedside nurses and maybe really enjoyed their teaching role and everything that went along with that. But many schools are also exploring community-based education. And again, the same competencies apply. It's just how do you then have an educator be well prepared to find and facilitate that learning in a community context. So, there's lots to be done here, and I'm glad that you guys are grant funded, because I'm always looking at grant funded opportunities to enhance nursing education. So I appreciate all that you shared with us today. It's a lot to be done, and there's a lot still to be done, and there's a lot of room to kind of work to improve that whole salience of the educational experience. It's not just about what they have to cover in terms of their learning objectives, but putting it in context for what they need to do as nurses.
Absolutely, Michelle. Thank you so much for your hard work on this. You hit the nail on the head. This is the challenge of clinical education, whether it's in direct care situations or whether it's in simulation. And so it's incredibly important. And I would offer, if you would like, to just send me an email. It's Garrett at healthimpact.org. We have another group division within Health Impact called the California Simulation Alliance. And the director is Dr. KT Waxman. KT is a past president of SSH, you probably know. So we do a lot of education of faculty related to simulation. We have courses, and they're also done. We can do them distance wise as well. And we have had conversations with KT and her manager of the California Simulation Alliance, Dr. Alexandra Duke. And so we're trying to start moving things together and synergize a lot more. So be happy to have more conversations with you in New Jersey to see how we can partner or support whatever you're doing. This is great. Well, thank you, David, for the opportunity, and thank you all who participated today. And it was really exciting. And I want to give a huge shout out to Eddie for his strong work and perseverance and putting up with me. So I think we're getting much farther along. So again, thank you, everyone.
It was wonderful.
Thank you so much, everyone.
Wonderful. And I will plug, we do have one meeting next week for a few of us that were, or next month, we have the next meeting. It's on like, well, it's balancing like, you know, teaching and clinical, right? Right, Rebecca?
Okay.
Yes,
You're going to do that.
It'll be a discussion. Yes, we're doing, I'm co-facilitating. But the role of the faculty member in the academic setting, and how there's that tension between being the expert clinician and also being the expert educator, and meeting all those criteria when it has to do the publishing or perishing and all this stuff for tenure, and it's research, it's service, it's being an excellent teacher, all those tensions. How do you balance that? So that's what we'll be talking about.
Yeah, August 17th. Put it on your calendar. Save the date.
Awesome. All right.
Thank you guys so much.
Thank you.
Thank you.
Okay.
Take care,
Take care.
everyone.
Yep. Thanks.
Have a good afternoon.